politicians, executives of major companies, celebrities, and other prominent individuals. So this is also called VIP syndrome or recommended syndrome. We all encounter patients who are considered VIPs for one reason or another, and proper management of these VIP patients can offer downstream benefits to a practice or academic institution in the form of bolstered reputation, practice growth, and many a times funding. So this was a study. This was in 1964 by Dr. Wintra, the VIP syndrome, a clinical study in hospital psychiatry. So it seemed that shorthand for how the influence of wealth and the allure of fame can cause doctors to veer into risky territory when they cater to stars. They may reject medical advice, can demand ineffective or alternative treatment. Star drug doctors can actually advise unnecessary or inadequate tests, and they may insist to see by the HOD or the chair of the department, though which actually may not be necessary for all cases. So prerequisites: caring about this person's status and whether to simply treat them the same way you would treat any other patient with the same eye problem. So it's okay to roll out the red carpet, but it's better to follow the SOPs of your practice. Waiting period should be less. Offer preferential appointment scheduling to accommodate the VIP schedule. And your delivery of healthcare to the VIP patient is no different from your delivery to healthcare to any other patients. So you're all aware of this, the last days of the king of pop. So avoid the syndrome, because when doctors allow a VIP patient's broader social status to influence the medical decision making, the consequences can be dire. So you cannot be the supplier of milk, as Dr. Conrad Murray did to the pop star. So don't get extracted or diverted by the VIP status. Think clearly, be relaxed, and stay within the standard of care. So if you come to floaters, because all these symptoms, the specks, the lines, the circles, the cobwebs, which appear to float inside the eye, cast a shadow in the retina, can be annoying, definitely annoying for all of us. So, but usually decreases with few months of vitreous separation, and sometimes, but very rare cases, can be persistent also. But what actually we have to keep in mind that this can actually lead to reading difficulties in 50% of patients, and 30% can have driving difficulty. There are few reports of suicidal attempts because of persistent floaters. Pathogenesis is not needed, but sometimes few may need to be explained about why actually is happening and what actually is happening inside the eye. So flashes, the physical stimulus, the next symptom, where we have a vitreous pooling part of the retina, usually appears and fades quickly, and there is a specific pathogenesis of this, that we see the vitreous syneresis part because of posterior vitreous detachment. And I usually keep a very simple rule of telling patients that more than 65% patients above the age of 65 years probably will have a physiological symptom of this posterior vitreous detachment. So it can have intermittent blurred vision or glare or haze, but need to be aware of the complications which can actually cause because of AMD, such like you can have a retinal tear or break. So these patients can be triaged depending upon the symptoms. So symptomatic patients to be re-examined, because there is a possibility of having retinal tear in 3.5% of patients. So, and you can see this patient earlier, so be it a VIP patient or a normal patient. So these are the simulating conditions where we can actually have flashes, where migraine, occipital tumors, vertebrobasilar TIAs have shown to have these symptoms. Glares and halos can be after cataract surgeries also, sometimes after refractive surgery. It can be because of vitreous hemorrhage with PVD and retinal tear, vitritis or retinal detachment. So these symptoms we need to actually see what actually we are seeing. So examination proper is very important. We see vision, we see anterior segment. There is an history of anti-VEGF injections need to be checked. Dilated fundus examination is depression. Ultrasound can be of benefit in some cases, not OCT. And urgent referral, if your anterior segment surgeon is better to refer to a retina specialist explaining the disease to the patient. So treat peripheral retinal degenerations as and preferred practice. And I usually follow there's some guidelines where actually it helps patients to explain, and so you definitely have some dummy eyes or these illustrations I usually give in the OPD, normal retina for a abnormal retina or a detached retina. So this helps a lot to explain the patients. So you will have a retinal break in these patients, you have a retinal detachment, a local detachment in this patient, you have a total retinal, quite a significant retinal detachment, and this is the normal macula. So this helps in explaining and probably planning your treatment part. So treatment as well as reassurance. This patient had floaters and flashes and a symptomatic like this retinal tear. So it was lasered, and you show the picture to the patient. Once you can take a pulse photograph, patients are reassured. These are other pictures where you see a horseshoe tear was visualized, a horseshoe tear which has been lasered, laser marks are there, no detachment. These few things probably helps. But if you have a persistent symptomatic floaters in patients, because most of the doctors feel that it's a minor ailment, doesn't require any treatment, but yes, there can be 33% patients who have noticeable vision impairment, migraine, 6 points, but patients can have anxiety and sometimes, as I told that, they've considered suicide also. So intervention worth considering in cases where you have a significant moderate to severe floaters. So these are the few surgical techniques, lasers and surgery things we followed. So I'm not going into the details of this. This is the chart what actually I give to patients. Very important that the line here is very important. When you examine today, there was no sign of any damage. So this is medico-legally also important. So reassurance, always reassurance if you don't have a symptom. But if you have a VIP coming with this condition, I wish you all the best. So conclusions, sound understanding of the basic physiology of the disease. Treat VIP patient as any other patient with needed modifications in the approach, not treatment. Floaters and flashes can be annoying, and the key words to handle the symptoms is patience for both the parties. And this is the VIP I follow, bow to value medical skills, intend to command the medical aspects of the situation, and practice medicine the same way we see with all patients. Thank you so much.